Let's start with our lecture, people. I will start sharing my screen. So this is our chest X-ray. I have updated it with the most updated Turkish version. Now it's 230 something slides. Chest X-ray is the most common radiological examination worldwide. The indications of it is numerous. It doesn't end. There's 20 indications here, but it is not the end. It will be very commonly performed in your practice in the future. Like you will be seeing a lot of them. When we come to projections, there are a lot of projections, but there is basically 2 or 3 projections that you will be using. The standard one is the posterior anterior projection. Uh, by by saying that, I mean the X-ray rays is coming it's entering from the posterior and is getting out from the anterior perspective. So when I talk about an AP projection, anterior posterior projection, I'm talking bedridden patients which is staying there, and we are making an imaging with the portable X-ray. Okay, so if you can do it, you should do PA projection, which is more common. Also, there is lateral projection as well. We will come to that, and there are some additional projections that we can use also. PA is the standard one, as I have told you. It's the patient should be in full inspiration and hugging the detector. When you hug the detector, the scapulas get to the lateral side. Okay, it's so the lung areas are more visible. The advantages of this is it does a very good visualization for the lungs and mediastinum. Also, the heart size is measured in a better manner. When you go to the other projection, you usually use it for bedridden patients, the AP one. The disadvantages of this is when you do an AP lung X-ray, the heart is sitting more on the front side. So because it's closer to the detector, the heart gets bigger actually. So it closes the lung areas because it's getting bigger. Also, the scapulas are entering the exam. So here on the left side there's a PAP, and on the right side there's a PA projection of the same patient. So you can see the difference. The scapulas are entering the area more, entering lung area more, and the heart is bigger. So it is we are seeing less of a lung tissue here, unfortunately. The lateral projection is it's performed seldomly, let's say. The advantages of this is that you can see the retrosternal place and retrocardiac space, which you have the effusion first. Like when there's minute amount of effusion, because of the gravity, it fills in the posterior area. I have told you in this WhatsApp group. So also the radiation dose on laterals is much higher, like 5-6 times higher, because the rays are traveling through more tissue basically. So it's not a very commonly used. Also, there are other very uncommonly used projections like lateral decubit position. You can see the pleural effusion much better, of course, when you lay the patient on sideways. But in my 10 years of radiology practice, I never reported a lateral decubitus lung X-ray. Let's put it out that way. For expiration graphs, you can see the foreign bodies and air trapping much easier, because if the air is trapped on an expiration graph, radiograph, you see it better. The lordotic ones on the top here, you can see the apex of the lungs better. And on the right side, we are seeing a small nodular lesion here. If you're seeing it, I don't know. Also, the right and left anterior oblique graphs, we sometimes do it in patients who are suspected of costofractures. You see the ribs much better with this. So after finishing the projections, let's come to the technical evaluating the technical adequacy of an X-ray. This can be a very good exam question. Let's go over it. So how do we differentiate a good chest X-ray from a bad one? This is how we answer the question. There are four main factors which can affect the quality of an X-ray. Okay, one is the exposure, like the dosing of the patient. How many X-rays, how much dose of X-ray are we going at? The other is the inspiration state, and the others two are basically rotation of the patient in one axis or the other. Okay. When we are evaluating the dose of the patient, X-ray dose, we use uh, two factors. We should see the vertebral bodies individually behind the heart. So in the retrocardiac space, we should be able to somewhat see the vertebral bodies. If the dose is not enough, it's much of a brighter tissue, so brighter film, so you don't see it. Also, you should be seeing the areas of the lungs. Okay. Uh, Please excuse me for 1 second, please. Uh, I'm sorry, people. So we look at the exposure of the X-ray by looking at the vertebral bodies, and if if we can see the lung bronchovascular markings in a good way or not. So there is two factors to evaluate when you are looking at the dosing of the patient. Okay. When you look at the inspiration state, you have to count the ribs to do that. You either count 9 ribs from the 9 or 10 ribs from the posterior, or you count 6.5 ribs from the anterior. 6.5 means the sixth rib is going to end. The middle part of the sixth rib is going to intersect to the middle part of the diaphragm. Okay, so let's look at this. I'm counting the. I will count. I will start from the posterior one. This is the first rib. First one, 2, 3, 4, 5, 6, 7, 8, 9, and 10. If I see 9 or 10 ribs, if I count, it's an adequate inspiration. I'm counting from the front now. The front is like more oblique. Okay, it's going to the front area to sternum. This is the first one. 1, 2, 3, 4, 5, and 6. It just intersects with the middle part of the diaphragm. So this is good inspiration. Okay. But when there is some pathology, the numbers can be different. So when I'm counting the ribs from here, 1, 2, 3, 4, 5, it actually ends in 5. So this is not an adequate inspiration. Also, when the pathologies are obstructing the view, so you can count less ribs in an even good inspiration state. Are you detecting something on this patient? I have actually pointed out there is pleural, there's blunting, right? On the both sides, costophonic sinuses are not sharp, but blunted. Also, there is quite an amount of effusion on the left side, right? So this comes from the same patient. When the patient doesn't have enough inspiration, okay, let me count ribs from the anterior. I always count it from the anterior as a radiologist. 1, 2, 3, 4. The fifth rib is intersecting. So the patient is not inspired, did the inspiration enough. But when the patient does the inspiration of 1, 2, 3, 4, 5, 6, 7, you see the heart size is marginally changing, because when you're doing expiration, the heart is basically leaning a little bit. So in not enough inspiration, the heart usually looks bigger. You should note that. Okay. So we end the inspiration here. We come to the third one and the last two ones, which is basically rotations. The rotation on the left-right axis is evaluated by looking at the clavicles and measuring it with the spinous process of the vertebra. Okay, they should be on the left clavicle, and the right clavicle should have the same distance to the middle part of the vertebra. These are some schematic representations. So when the patient is not rotated, we see them with the same distance. When the patient is here rotated a little bit to the right side, and when the patient is rotated, the clavicle comes, the left clavicle comes closer to the spinous process. Okay. So is there anyone that can evaluate these patients? I have actually written that. I'm expecting.
Is it a pneumothorax?
Pneumothorax? Definitely not. Where did you see it? Where is the pneumothorax?
No, because the apexes of the
The
lung,
left side to me.
it's not
The left
symmetrical.
side. Yeah, they're not symmetrical, but there's a rotation of the patient. The patient is leading a little bit. Okay. Also, there is some asymmetry in the lung areas, the density of the lung areas. So this can be evaluated. I actually put this only for technical evaluation. Let me go at the dosing. The dosing, I can barely see the vertebral bodies. This is some film which is scanned back, so the quality is not as good as a digital one. So the dosing is pretty much okay, I can say that. And when I count the ribs, let me count them: 1, 2, 3, 4. Obviously, we can see the inspiration is not enough. On the posterior side, they have counted 8 ribs. Also, are you seeing some rotation? I'm seeing some rotation. Let me draw it here. One of the clavicles is ending right here. The other clavicle is ending right here. The vertebral bodies are here. So the patient is rotated, right, to this side. And also not, the inspiration is not enough. So, and for the other... Buyurun.
Is it the same if the patient has a scoliosis or something? Like,
Yeah. We don't have a new rule for scoliosis patients. It's just these 4 rules that you have to always. Of course, you have to, well, use your mind to evaluate the situation, since you can see the outlines of all the organs. The rules are 4 rules, and the criteria are very strict and very basic on this one. What about these? Okay, I didn't mention the rotation in the other axis. Let's go over that one as well. So we have been evaluating the rotation on the left-right axis, right? If the patient is rotating to left and right. Also, there is the rotation in the other axis. If we are looking from below the patient or above the patient, that can marginally change our findings as well. And that's called angulation. You can call, the names are not strictly important. You can call them something else. It's basically the rotation in the other axis, we can say that. To evaluate that, we should look at the clavicles, and the clavicles should intersect the third and fourth ribs on the posterior side. Also, the lung apexes should be visible. You can use one of them, which is enough. So when you're doing a chest X-ray, the clavicles should intersect to the posterior fourth rib. So this is the first rib, this is the second rib, and this is the third rib, when I count from the posterior. So the clavicles are intersecting to fourth rib here. Also, I can see the apexes. If I can see the apexes in a good manner, I can call it the angulation is fine on this image. Let's go to the other one. So when you're shooting from below the patient, and you're shooting to cauda cranial axis, a little bit angulation on the caudocranial axis, then the clavicles are going to just superpose to the apex of the lungs. So you're going to have a hard time evaluating the apex. So this patient has strict angulation technically. But more than that, just don't look at this area. Look at what happened to the other organs. So because when I'm shooting the heart right in the middle part of the lungs, now I can see the heart in a very disoriented manner. Also, the shape of the diaphragms are changing marginally. I cannot see the left border of the diaphragm, so I can hardly see the costophonic sinus here. Here I can see it, but many of the lung areas are also compromised because of the diaphragm superposing to these lungs tissues. So the angulation can really distort the image. Okay. So recognizing a technically adequate X-ray, evaluating the technical adequacy of an X-ray. There is 4 factors. We look at, for exposure, we look at the vertebral bodies. Sorry for not writing it, but you have to also look at the lung tissues. You should be seeing the bronchovascular linings in an X-ray with a good dose. For inspiration, you count the ribs. For rotation, you look at the clavicles. For angulation, you also look at the clavicles. This can be a good question in the exam, and it is actually asked in the 2 previous groups. Okay. Can anybody come for a technical evaluation, please?
I can do it.
Please, doctor.
So when I look to vertebrae, I cannot count them.
Yeah.
So it's bad penetration.
Good.
For inspiration, 1, 2, 3, 4, 5, 6.
You're counting
7,
from the posterior ones, right?
9. Aynen. Yani posteriordan, when we look at from the posterior view, there is 9
good doctor.
costas, so good inspiration.
Yeah. You didn't see the anterior ones, so you counted the straight posterior ones, which is very good. Okay, doctor.
Yes. For rotation, I cannot see clavicles well, but it looks like it's good.
Okay, rotation. I'm seeing some experience here. Good one. Yeah, I cannot see them as well, but it's symmetrical, right? I can see it's pretty symmetrical. Good. So the rotation is good.
When we look at the angulation, clavicles are above the apex, so it's bad angulation also.
Definitely. So 3 of the 4 factors are not enough. Only the rotation is good. Thank you, doctor. That was a very good evaluation. In the oral exam, I want you to be very fastly go through these technical parts of the chest X-ray. Okay. This is one of your duties. You should start with the technical and then go to the systematic approach for pathologies. All right. Let's look at the other one. Can I have a volunteer, please?
Me, hocam.
Yes, doctor.
I think we can see the vertebrae, so the penetration is good.
Good, yeah,
and
me as well.
We can account 1, 2, 3, 4, 5, 6, 7, 8 for the posterior ribs.
Let me draw the anterior. 1, 2, 3, 4. Okay.
Not enough.
Not enough. Good.
For the rotation, there's no symmetrical ventricles, so I think there's addition to that.
And I had trouble hearing you with this one, but the clavicles are left side is closer, right? I have drawn that, so the patient is rotated. And for the angulation,
we can see the apex, so it's there's no angulation.
You can see the apex, but if I look at the posterior ones, I'm seeing actually, I think this is the 5th one. The 5th one. So it's like coming a little bit down, right? It's coming a little bit down, but I can see the apex, so it's not that much of an issue. If the rotation is increasing, of angulation is increasing, and the clavicles are going down, then you will have trouble visualizing the costophonic blunting and the diaphragms. Okay. All right. This was sort of angulation was sort of good. Thank you, doctor. Here's another one. When I count the ribs, 1, 2, 3, 4, 5, 6, it's good inspiration actually. The dosing is terrible. The rotation is, I can hardly understand the rotation, but it looks okay to my eye. But the angulation, when I look at the angulation, it is covering up the apex, right? I cannot see the apex clearly. It's superposing. So the angulation is bad, rotation is good, inspiration is good, penetration is terrible. All right. It's basically it. So we will start with 5 sample cases. We have gone into technical and the technical and the, all right, we will go a little bit on the dosing as well. After finishing the technical, I wanted to put this part. Does anybody see a pathology? Please, can I have some volunteers? Like, please mention what you see as abnormal. You can talk about anything. You can make mistakes. I'm sorry?
Cardiomegaly is seen.
Yeah, it's true.
Costophonic angles is barely seen.
Barely, yeah.
Also, is there a lesion like in the left lung?
This one, right?
Yes.
Can anybody name? Yeah, this is aneurysm, right? It's an aneurysm on arcus aorta. It's a huge one. It's a very dangerous aneurysm. Thank you, doctor. Can anybody see some? Can anybody see some abnormality here?
Is there effusion?
Where?
Like in the right, yeah, this.
Hocam bağırsak ansları görünmüyor mu orada? Sanki ben öyle görünmüyor.
The costophonic sinuses are open, right? So there is not an effusion here. I'm sorry. I'm sort of seeing the the posterior space as well. It's open. There is no effusion here, doctor. We are seeing some some bowels through that. Can you name them, doctor?
Mustafa hocam.
Can you name them, Mustafa? No, I'm not. I was saying name them, not yourself. What are these? These are large bowels, right? Look, there are haustras. They are not villus. It's not like this. It's big haustras. So these are large bowels. So this patient has some retention, definitely, in the bowels. What else?
Üst tarafta nodüler bir lezyon var. Sol
Oh,
ciğerde.
great doctor, great doctor. I congratulate you. You are the first person to say that. It intersects with the first rib, so it can be something on the first rib as well, but there is definitely some asymmetrical appearance here. If I look at the lateral graph, there is something else. So it's something faintly, I can see something. So there is a high probability mass lesion on the lung here. Very good, doctor. Left lung apical lesion. What can you say to that?
The left humerus, there is enchondroma. The right humerus.
All right, you have watched the lectures, right?
Yeah.
Okay, good, doctor. So we are seeing a lesion on humerus here, right? On the right humerus, there is a bone lesion, which is definitely out of scope of the lungs here. We are talking about, right? This is some right humeral head chondroma or low-grade chondrosarcoma. It can also be. What about this one? We've seen this patient like a few slides ago.
Pleural effüzyonu var galiba
Yeah,
hocam.
pleural effusion. There is some blunting here, and there is some definite effusion here. Okay, now we are seeing pleural effusions. Good. We are seeing a right subclavian catheter. We are seeing a little bit cardiomegaly, and the pulmonary artery is a little bit prominent. So it can be pulmonary hyper. This patient can have pulmonary hypertension. And what about this one? These are asbestos plaques. There's a pleural plaques. Okay. What about this one? This doesn't have an explanation. You have to do it yourself. Merhaba. Okay. We are seeing
Sağda
some...
pnömoni var.
Nerede doktor bey?
Aşağıda çünkü kalbi silmiş gibi gözüküyor. O tarafının gözükmüyor kalbi yani.
Burasının mı gözükmemesinden bahsediyorsunuz?
Evet.
Ama buranın densitesi düşük. Buranın densitesi daha yüksek. Pnömoni olduğunda densitenin yüksek olması lazım.
Okay.
More than that, doctor, I'm seeing some asymmetrical appearance on these areas, right? Like there's some big asymmetrical appearance on between left and right side. So ikide şey varmış abi, boşaltacağım. So there is definitely some increased density over there, like we're gonna try to name it. Also some increased density on this side and not on this side. So can we try to evaluate what's going on here? Barah Süleyman has told mastectomy, which is very good. I'm seeing the breast here. This is actually the breast tissue. Here I don't see the breast. I don't see the breast lining. So it's actually like this difference is coming from mastectomy. The patient is missing a breast here. But on the top side, our findings are just reversed. So there is some increased area of density on this side. All right. So we will go over these kind of things, but I was trying to mention you people about the contents of a typical chest X-ray. So as we are looking at the image, we have gone through numerous pathologies, and none of them was at the same place. So there are many different areas that we have to evaluate in a chest X-ray. There are many organs that are superposing one on each other. And sometimes obstructing each other as well. So can we? How are we going to do it? It's an important question. So we should always approach a chest X-ray systematically. This should be a must, because if you are just looking at the image and just trying to figure out what it is, there's hardly, because when we are dealing with such a case, for example, there are many pathologies intersecting with each other. We can easily miss a lesion which is on the bones, for example. This is not a bone lesion, by the way, don't worry. But there could be a bone lesion that we have missed easily. But if when we are looking at the chest X-ray, we should be looking at something, not directly at some, not everything. That's what I must try to say. So we should have a systematical approach in our minds. There are a few approaches. One is A, B, C, D, E, F, which is, and this is the like the longer version of it. The shorter version is A, B, C, D, E, F, is airways, bones, cardiac silhouette, diaphragm, and effusions. You can follow these ones. Or I usually do it in a geometrical manner. I start from outside and I end up in the vertebra in the very end and behind the heart and diaphragm. So I usually, personally as a radiologist, I start from the most lateral space, looking at the bones of humerus, clavicle, and the scapula. I look at the soft tissues of the neck and the chest. So when I go in, I always evaluate the Costophonic angles. and I look at the pleural space, pleural linings, if I can see something. I look at the costa, and after that I evaluate the lung areas. Then I look at the heart, I look at the mediastinum, I look at the airways, and I look at the bones, the vertebra. I never forget the apex of the lungs. And in the very end, I decrease the brightness of the image always to see if if I miss something on behind the heart or behind the diaphragm. So the terminology of chest X-ray is pretty basic actually. When the X-ray penetration is less, the brightness of the image increases. We call it density in X-ray. In ultrasonography, we call it a cogenity. In MRI, we call it an intensity. I will not ask this question, don't worry. So when something is getting opaque, we call them radio opaque or dense. When something is getting darker, we call it lucent or radiolucent, okay? So when we are describing things, we say there is faint opacity in the right middle zone, something like that. So the brightness actually changes with the density of the material. Like if there is a metal, for example, it looks much brighter. Also, it is related to the thickness of the material. Okay, if there is very thick, if the patient is very thick, then the penetration is low. So I got a question here. I actually told this before. When we increase the dosing of the patient, does the image get brighter or darker? Darker, right? You can see when there's only air, when there's too much of an X-ray, the image is actually getting darker with X-rays. When you're shooting the X-ray, you are actually you can interpret this like you are burning the image. Okay, so more X-ray source means darker image, and X-ray exposure affects image quality directly. We have seen it before. It's a part of our technical evaluation. So the density, I mean the brightness of the images evaluated is affected by the density of tissue, the thickness, and also the exposure. There is some dosing schemes here. I'm not gonna ask them anyway. So we have talked about the projections. The AP view is usually in bedridden patients, and the mediastinum and the heart is not looking nice, it's looking bigger, and lung area is compromised. We have did this comparison. And I remind you the technical part of technical evaluation as well. Please remember. So the technical evaluation and the terminology of the chest X-ray is completed here. The technical points make very good written questions, so please know them, not memorize but know them. We will in our next lecture we will move on with anatomy and the pathologies. We will do a systematical approach. That's basically it. So let's not make a break. Let's move on. I feel the power. I think you have the power as well. I will be sending the link. I will just change the room and send you the link in a few minutes. Okay. Let's make a small break of 5 minutes. Let's start in 2 o'clock. Right. So we will start with the anatomy now. So as I have told you people before, in a typical chest X-ray, there are many structures obscuring, superposing each other, and looking at and simply existing at the same place. So when you are looking at the image, since you are also a starter, this applies to me as well. Like I do the same thing really in my radiology practice. I'm a 10-year-old radiologist. I'm a 10-year-old radiologist. So the systematic approach is a must. If you don't do that, there's a high chance that you are missing stuff. You're a human because if you just look at it like with only your with only not thinking about anything and generally looking at everything, it's a big mistake. Okay, so there are many tactics to do that. One is A, B, C, D, E, F. I use the geometrical way, as I have told you. I start from the most lateral, most outside, and I go inside. You can start from the inside and go outside as well. Like the opposite can be true. But like I've tried them all. But for me, which fits it best was to start from the outside, because when I evaluate the outside and the soft tissues, then it's just the lung and the rest. So I feel myself more comfortable doing this. I start with the bones. I look at scapula, the clavicles, and I started to go and I look at the soft tissues. When there's a big axillary mass, for example, you can see it with a chest X-ray. You look at the breast, you look at the Costophonic angles and started going in. You look at the pleural linings and see if you can find anything. And you start to look at the costa one by one, like area by area, sorry. You look at the lung areas, you always not forget the apex. And after then, I sometimes look at behind the heart and behind the diaphragm. Sometimes leave it to the very end. Then I go in and look at the heart, see the big vessels, the major vessels, the hilum of the lungs. Yes, please. Let me finish.
Can you share the screen?
I don't share the screen. Oh,
Yeah.
all right. You should have reminded me this before. Oh my God. Oh my God. All right. These other slides, you have seen them before. So, yeah, this you have seen it before, like the A, B, C, D, E, F way, or my way, starting from outside. I was telling you from an example. As I have told you people, I start from the very outside. I look at the humerus, I look at scapula, the clavicles, and the outer bones. I look at the soft tissues. I look at the axillas. I look at the breast, if I can see any abnormality. Then I start going in. I look at the Costophonic angles, and then I start following the pleural linings, if I can find anything. I will look at the costas, like area by area, and then I evaluate the lungs. Never forget the apex, and I then look at the behind the heart and behind the diaphragm. Usually, I sometimes leave it to the end. I look at the heart, the major vessels, the arcus aorta, the hilum of the lungs, and then I look at the airways. I look at the vertebral bodies, if they're all symmetrical, and then I look at behind the heart, the diaphragm, and that's the end. If you evaluate everything with this, your chances of missing stuff is greatly reduced. Okay. So in the oral exam, I will be asking you people when you're sitting in front of the screen. You may not be seeing the pathology in the first look. So, like some of the scans are difficult ones. So if you're missing stuff, just start the systematic approach. Like many of our students, previous people in the oral exam, they didn't find it in the first, but in the first round maybe they didn't. But in the second round of the systematic approach, they usually find the abnormality. Okay. So let's start from let's talk about chest X-ray anatomy a bit. How many lobes do we have on the right side? We have 3 lobes. On the left side, we have 2 lobes. All right. On the left side, because we have the heart, we have lower number of lobes. You can think of it like that. All right. So the oblique fissures they exist on both lungs. On the left side, it divides upper and lower part. On the right side, it's between middle and the lower lobe. Okay. And on the right side, you have also the horizontal fissure, which is between the top lobe and the middle lobe. Okay. So 3 on the right, 2 on the left. The right superior lobe is basically like this. It's we can see the lining on the horizontal fissure. So if we see something which doesn't cross the horizontal fissure, it is on the top lobe, right? if we see something which doesn't go to the top but stays on the bottom part of horizontal fissure, then it is on the middle lobe, okay? Because the horizontal lobe is between the top and the middle, okay? The right middle lobe is located in this area, and the lower lobe is here. So if we are looking at this thing, you can realize that even the top and the lower lobe has some common superposed areas in a PA X-ray, okay? So when you're talking about an area in the lung, you should always talk with zones, not lobes, because you cannot see the lobe all the time, almost all the time. So in which lobe do we have the infiltration here? There is lateral chest X-rays on oral exam. Can you see the lobe? Can you guess the lobes? So I'm seeing the horizontal fissure, right? There is some area of increased brightness here. I'm seeing the horizontal fissure, so it is on the bottom part of the horizontal fissure, which means that the thing is actually located in the middle lobe of the right one, okay? But here, let's look at it. Which lobe can we say the pathology is located? It's impossible to say. So we are going to use zones in chest X-ray, okay? You are not a CT scanner. You don't describe lobes, but you talk about zones, okay? Left middle zone, right lower zone, some things like that. But if you see the horizontal fissure, then you can guess where the pathology is located, because you know where the horizontal fissure is, and on the top of the horizontal fissure, it's right upper lobe. On the bottom part of fissure, there is the middle lobe. Okay. So the left upper lobe is here, and the left lower lobe is here. As you're seeing, it's almost all superposed. So we're coming at the bones now. Let's look at this X-ray and try to see the abnormality.
Is there a fracture?
There's fractures, right, on the left side. I'm seeing some intubation tube here. The patient is intubated. It's this one. The bright one is nasogastric tube. It goes to the bottom. Can you see my screen well? Like I'm receiving warnings about internet connection. Do you have problems? No. Okay. What else? I'm seeing ECG probes. What else? So I'm seeing some marginal difference between right and left lung. There's some areas of increased density in almost all of the left lung. This can be due to contusion, because there's probably this patient has a lot of costofractures here, like this one, this one, this one. There are multiple costofractures, and there is some area of air, like outside to the hemithorax. So it was a major trauma that causes big area of contusion in this lung. But this can be very well pneumonia if there was no costofractures. Okay. Also, all new fractures look like this. There's some discontinuity in the cortex. About old fractures, because they heal after time, they have a sclerotic look. Okay, so when you're seeing something like that, it's sclerotic. It's old fracture. These are areas of old fractures. So there's an area of hypertrophy. And let's have a look at this one. Does anybody see the pathology? I'm giving you 5 seconds. The right clavicle is fractured. Let's try to see something else, because there can be other things in this area. I'm not detecting anything. Okay. Here we have fractures on the left side. Depleted fractures look like this. And look at this one. So there's some prosthesis material on the clavicle. This is a very wrongly made X-ray, right? It's probably not a chest X-ray. This is something else. The end of clavicle is here. The other clavicle is, I think, here. So there's enormous amount of rotation. Does anybody see anything? We're seeing broken bones, right? Okay. All right. Let's have a look.
Hocam, do we need to
Yes?
we need to know if it is from the posterior or the anterior ribs?
I'm sorry?
We need to know the fracture in the posterior or the anterior ribs.
Of course. Do you see it in the posterior or on the anterior side?
It's in the posterior.
This is in the posterior, right? We know which are the posterior images and which are the anterior images from counting the ribs, okay, for inspiration. Okay. So, does anybody see any abnormality in this image? There are a lot of abnormalities in this image.
In the right, there is old fracture in the right.
There's old fracture, right? Okay.
Yeah.
This is some area of increased density, right? But not all sclerotic areas are old fractures. This is a sclerotic area for a very long segment, right? So if this was a fracture, it would be something like this, some hypertrophy here, but this is a long segment. I'm seeing some other things in this lung X-ray. If you have a systematic look, we will see a lot of things in this image. Let me show them one by one. I'm actually seeing some prothesis on the left breast, right? So the patient has actually left mastectomy. Also, I'm seeing a port catheter here. So the patient is probably still receiving chemotherapeutics. The patient is receiving chemotherapeutics. It has a mastectomy and it has a sclerotic costal lesion. So the patient this is probably some metastasis, because the breast metastasis usually are sclerotic metastasis, and which has gone under operation and receiving chemotherapy right now. So looking at the chest X-ray, you can sometimes gather things together and make up the whole story, right?
Hocam, so you mean this is not an old fracture, it's a metastasis?
It's a metastasis. It's probably, I don't have the biopsy for that, but it's very, very highly probably that this is a sclerotic metastasis. When we see dense lesions in the bones, like not all of the lesions are fractures, right? There can be other things in the bones as well. It can be sclerotic metastasis. It can be some primary bone sclerotic lesions. It can be osteomyelitis in the chronic form. And I have written that also Paget disease can manifest itself with a sclerotic look. Okay. Can anybody see it? I think this is pretty obvious, this one. It's a sclerotic lesion, which is a very long segment. Okay. So this long segment is probably not an old fracture. It's probably a sclerotic bone lesion. Mostly metastasis, because it's a very long segment, and the cortex is pretty much intact. So when we look at the lytic lesions, that can be dense or lytic. The lytic lesions in bones are pretty much, if you see the etiology, it's just the same. It can be lytic metastasis. It can be also primary bone lesions which have lytic nature. It can be new osteomyelitis. New osteomyelitis, first osteomyelitis decreases the density of the bone, and then Paget is also both lytic and sclerotic. So I'm asking you to differentiate the lesion. Does anybody see it? This is a very hard one, by the way.
In clavicle, I think. Or
In clavicle, let me check the clavicles. I'm not seeing anything. Okay.
On the left side.
It's here. It's a lytic lesion with expansion of the cortex. Okay. Systematic approach. There is only one way we can do this. Okay. There's another lytic bone region which is marked here, so we cannot follow the ribs. This is all for the bones. When we look at the airways, it can be narrowed, it can be deviated, or it can contain foreign objects. So we should always look for all of them. The foreign objects are, when they are on the big airways, it's easy to see, but when they are going on the deeper sides, and if they are from soft tissues, like nuts, for example, nuts can, it's impossible to see them. Okay. So let's have a look at this one. This is a pediatric patient with coughing, with rough coughing. Can you see anything? When we look at the lesion here, when we look at the airways here, on the top airways, there is some narrowing of the airways. This is a typical case for croup, which is very common in children. Okay, so you should be following the airways all the way. When it is deviated from where it is deviated, we can go to pathology. When it is deviating to the other side, and the pathology is on the left side, so there's probably something which is pushing the airways to the other side. So this case is probably some very big, very major pleural effusion, for example. But when it is deviating the trachea to the other side, then it is probably something which is pulling the airways. So it's probably some atelectasis. And can anybody see any abnormality in this image? This is very important. This is something you should be always looking for in the case of general practice. When I look at the lung densities, the density of the left lung is markedly decreased, than the right one. So there is big asymmetry in this area. So I can hardly see something, but either there is something which is increasing the density here, or something which is decreasing the density here. Okay. So in this patient, it was foreign body aspiration. When the foreign body is obstructing the airway, it is blocking the outway, but the inward, the inspiration is working in this patient, but the expiration is not working because the patient is trying to push and it is blocking the way. So these patients, because they are very small, like they are 1-2-year-old kids, they cannot say what happened to them. They will be usually just agitated patients, which is crying, and that's all. So you have to figure out yourself. And if you don't see if you don't recognize this asymmetrical appearance, you cannot go to the diagnosis. This is a 2-year-old patient with new onset wheezing. When I look at the airways of this patient, I can follow it here, but on here, it's getting markedly narrowed, right? It's very narrow on the bottom part. It's starting nicely. So this patient has a lateral radiograph as well, and the lateral radiograph, you can see the airway better. So this patient has abscess. It has swallowed and foreign body, which actually ripped the esophagus wall and caused an abscess in the mediastinum. We are seeing a mediastinal mass lesion, which is making deviation on the trachea here. So
Can you show me the abscess again?
you cannot see the abscess, doctor. You cannot see the abscess, doctor, because the abscess is in the soft tissues, and X-ray has very, very low soft tissue density, right? You can't see the abscess. It's just the diagnosis of this patient is abscess, but in X-ray you can only see the narrowing of the airway, and that's it. Okay. I think you can see the abnormality here. It's this thing that they use for library shelves. Can you see the abnormality here? Let me give you a bigger look. This is an old patient, right? This is not a child. And you can see the molar teeth here. So it's actually a teeth. The patient has swallowed its own teeth. So when you look at the airways, it's not only the large airways, but small airways have a lot of pathology as well. Peribronchial coughing is a very important thing that we see in bronchitis patients. It usually happens with children. So when I look at the wall of the small bronchi, it's usually very, very thin. When it is thick and marked like this, we should be suspected of suspect that there is some exacerbation in the bronchi. There is some not effusion, but there's some fluid in the bronchus wall. So this happens usually with bronchitis. Also sometimes with heart failure as well. So these are normal cases. Normally they will look like this. If they are thick and you can see the wall very markedly, you should be suspicious of, first in children, you should be suspicious of bronchitis. And asthma attack, in asthma attack we see this. The bronchopulmonary dysplasia it's a very complex disease, just you cannot go to the diagnosis with that. And you also, in case of heart failure, you can see this bronchial wall thickening. For evaluating the heart, we look at the cardiothoracic ratio. I use my fingers. I just point out the heart and try to fit two hearts in the thoracic cavity. If I can fit the two hearts in thoracic cavity, then the heart is normal size. If it is bigger, then the cardiothoracic ratio is increasing. There are many things to evaluate the heart chambers and everything. I will never be asking you these questions. Just note that you cannot see all the chambers of the heart in a chest X-ray. You can see some of the chambers. And this is a case of left heart failure, for example. This thing we are seeing is left atrium, but like we are past that age. These are technologies of the 70s. Like this was before we didn't have a chest, we didn't have CT scans with us. So the heart is either big or small. There are things like diagnosing follow tetralogy with the chest X-ray, this or that, but these are obsolete now. These are very historical knowledge. You can forget about it. This you should remember though. If the heart is very big and it looks like a very big torba, okay, very big bag of plastic bag, then you should always consider pericardial effusion, which can be fatal, life-threatening sometimes. Because it happens when there's a big amount of effusion, it just dilates the pericardium, okay? On CT, it looks like that. And on ultrasound, it looks like that, if you remember. This is a case of dextrocardia. In a case of dextrocardia, you should always go and ask the technician or repeat the scan, because these are usually technical mistakes. They just put the right and left mark on the wrong place. Usually it happens because of that. In like effusions, also pericardial space is a potential space. It doesn't exist. There is less than 1 centimeter of fluid there. But when the fluid is increasing, it then becomes an actual space. Okay. The widening of the mediastinum is mostly due to technical problems because of AP view, for example, and in rotations. In rotated patients, the mediastinum can look really, really big. Please remember, or not enough inspiration. If the patient is in expiration, the mediastinum gets bigger. But in this case, the inspiration is nice, rotation is pretty nice. So this is a case of lymphoma, for example. And I'm seeing some big area, some big deviation of the trachea. This is due to a multinodular goiter, for example. This is thyroid is going to retrosternal area and pushing the trachea this time. In this case, the mediastinum is nice, but the hilum is quite big. I'm seeing something which is obstructing the left hilum. I cannot see the blood vessels here. If I take the lateralography, in the lateralography, I see that this is on the front side of the patient. And the diagnosis of this patient is pericardial kyst. You cannot do this diagnosis by looking at the image. It is historical. Just note the abnormality and refer the patient to the CT scan. That's all. Also, in this case, I'm seeing a very big, well-demarcated lesion. On the lateral, it's on the posterior. When it's on the posterior, it's usually because of it originates from the neural tissue. Schwannomas, for example, usually exist in the posterior space. Do you see anything abnormal in this one?
Lesion in the left.
This is a case of aortic aneurysm. We are seeing the aorta very dilated and very big, right? It's quite remarked. Also this one, when it gets more severe, it gets like this. When it gets extremely severe, it becomes something like this. So aortic aneurysms are very important for us to diagnose. There are a lot of...
What is it
Yes?
radiologically the difference between aortic aneurysm and a mass lesion? Because I feel like
They are all going to look like soft tissue, right? They will all have soft tissue density, so you cannot differentiate an aortic aneurysm by just looking at the image. But well, this is probably not an aneurysm, right? Because the August aorta is pretty nice here. It can be some bubble aneurysm of the descending aorta. It can very well be that. You can never make the diagnosis unless you make a CT image. But this, for example, this is a tubular lesion which is starting from arcus aorta and going down. So if you call this a mass lesion, I would ask you what kind of a mass. This is not a mass lesion, it's a tubular structure, right? So in some cases you can, some cases no, you can't. In this case, I'm seeing the hilum of the left side remarkably very dilated. Also on the mediastinum, I'm seeing some dilatation. On this patient, I'm seeing the hilum of the lungs getting remarkably bigger. And here as well, the pulmonary vessels are like they are narrow on the periphery, but on the central part, the hilum of the lungs are pretty remarked, right? They are dilated. So all of these patients are hilar enlargement. When I see hilar enlargement in patients, what should I be thinking about? You can go from the etiology, use your medical information. Whatever there is in hilum can get bigger and make this kind of an appearance. For example, what are there in the hilum? There are lymph nodes, right? So if lymph nodes get bigger, they can make this appearance. And lymph nodes get bigger when there is lymphoma, when there is metastasis, for example, or when there is some primary lung cancer and it has metastasis, for example. Also in case of sarcoidosis, which makes hilar lymphadenopathy, and silicosis, which is a lung disease coming with hilar lymphadenopathy. Also, there are blood vessels in the hilum. So if the blood vessels get bigger, then you can have this. So pulmonary hypertension can have this look as well. Also, infections can cause the lymph nodes to get bigger and make this kind of an appearance. So tuberculosis, Epstein-Barr virus. So you can make the list longer and longer using this tactic. Okay. When there is also mediastinal widening or border is or threshold is 8 centimeters, you can think of the same thing. Thymus is there. Aneurysms can be that blood vessels are there, lymph nodes are there, esophagus is there. So anything can make the mediastinum bigger, which is existing there, right? Can you see the abnormality in this patient? I'm seeing the right hilum big, obviously. I can see that. Also, I'm seeing some mass lesion on the right upper lobe, right? Some very round lesion on the upper side. So if I connect these all together, it's probably some lung mass which has lymph node metastasis. Okay. In this area, in this image, I'm seeing a very remarked increase density with sharp borders on the left hilum. This can be some pericardial cysts, some pulmonary artery aneurysm, or aortic aneurysm sometimes. It's on the posterior, so it's probably some schwannoma or maybe an aortic aneurysm. So yeah, this patient was an aortic aneurysm. All right. So I want to speak you about silhouette sign. I will come to this later. Again, this is not very related with our area, but in order to differentiate the location of the lesions, we can use this sign. When two things are sitting right next to each other, they are obscuring their borders. For example, when there is left lingula pneumonia, I will have hard time seeing the left border of the lung. Usually the left border is quite visible, unless there is a very big case of cardiomegaly. Also on the right side pneumonia, I can hardly see the border of the right heart, right border of the heart. So silhouette sign can be a tactic that we can use to differentiate the locations of the lesions. We have talked about mediastinum. This is a young patient, and the aorta is very prominent. The heart is not. So when I evaluate this image, like if this was a very big heart and with this image, it could be okay. But with this small heart, young patient, and a big aorta, we should always be suspicious about a mass lesion in the mediastinum or an aortic aneurysm. It can happen with young people as well, right? So you should always look for the age of the patients. Can you see the abnormality in the scan? The right lung is a little bit bigger than the left lung, in my opinion. It's pretty much the same though. If I look at the border here, I'm seeing a border inside the hemithorax. The patient is right-sided pneumothorax. This patient. We will see a lot of cases of that. So we come to pleura. We finished mediastinum. We come to pleura with this. We are starting. So yes.
And this, no, yeah, this one.
Yeah.
Is the aorta normal? The arcus aorta is normal here, or it's quite enlarged.
Enlarged? Enlarged?
Yeah, I feel like
this.
Or is it because
I think you're looking at somewhere else. This aorta is normal sized, right? Your size is 4 centimeters normally, but this is obviously looking normal, doctor. If you don't see it as normal, your eyes is going to calibrate it. Don't worry. Like this is abnormal, right? This is abnormal. So pleura is
sorry, doctor.
Yes.
Can you go back to the pneumothorax?
Mm-hmm.
That doesn't look like emphysema, or like, I don't know.
Emphysema is supposed to be
Somehow.
Inside the lung, right? It's supposed to be inside the lung. Then why am I seeing the right border of the lung here?
Okay.
So there is something obviously outside the lung, right?
Mm-hmm.
Okay.
Okay, thank you.
Hocam,
yes?
Is there any fluid diffusion in the left side? Because the costophrenic is
Oh, great doctor. Great doctor. Yara, right? All right. Yeah,
yes.
I'm gonna give you additional points in the oral exam. Okay.
Thank you.
Good one. Thank you. So pleura is a potential space. It usually doesn't exist. It's just two pleural lines sticking to each other. Okay. But when there's something inside it, then you start seeing the pleural lines. And if there is liquid on the pleura, because of the gravity it goes down because the lung is light, right? So the lung is going up and the fluid is going down. And when there is air, then the air comes up and the lung goes down. All right, you should think of it like in terms of gravity. This is another case of right pneumothorax. I'm seeing the border of the lung. It's hard to differentiate here, but on the here I can see it. There is something that can be helpful for us. We call it deep sulcus sign, because the air is increasing the pressure and the content of the right hemithorax, the diaphragm is sometimes getting separated in this case. So when you see the deep sulcus in a patient, although you can hardly see the pleural lining, you should always think of pneumothorax. Okay. When it is very prominent, it is easier to see. So in a case of very big pneumothorax, the lung is actually falling down. So I cannot see the bronchus here. Then I'm just seeing an empty space and then just the bones. And the lung is increased density. It has decreased in the volume and certainly fallen down in hemithorax cavity. So deep sulcus sign is very important. Also, something that we should always keep in mind is tension pneumothorax. In this case, there is not big amount of mediastinal shift on the top, but there is definitely some mediastinal shift on the bottom. The right heart border is starting to get to the other side, and the lung area is compromised, and the arcus aorta is almost invisible in this patient. So this is a start of tension pneumothorax. We have talked about the treatment in these kind of patients. It's a very simple needle that you are going to stick on the lateral side, a little bit on the top, on the pneumothorax. Okay, on the side with pneumothorax. Can you see the abnormality in this scan? By the way, you have a lot of patients with pneumothorax in your oral exam. I want you to be clearly visualizing these lung markings on a case of pneumothorax. This is a very important thing, that these patients are going to come to you in a very busy day, very young patient, you're not suspecting anything, and these patients usually have very mild symptoms like a little bit of chest pain, but it's actually something which is pretty dangerous. Like this can easily rise to a pneumothorax and be life-threatening. We have a minute remaining, by the way. Let's see, what do we have? All right, we have a lot to go on pleura, so let's stop it here. It's 2:40, and let's start the other lecture at 3 o'clock, exactly at 3 o'clock, okay? Or 5 minutes to 3 o'clock. It can be like, let's give a 15-minute break, then go on with our next lecture. Okay. Okay, we are late recording again. We were going through cases of pleural effusion, pneumothorax, and in the case of pneumothorax, when there's air inside, the lung is falling down, and we see the border here. Also, one other thing that we can do is that we cannot, to detect this, is that we cannot follow up the bronchovascular linings to the very lateral part, where inside in some areas there is just bones and no lungs. This can be a clue. When in big cases, it's easy to diagnose and it's getting dangerous. In very subtle cases, it's hard to detect. You should always look for bronchovascular linings and look for pleural lines when you are looking at a lung X-ray. Okay. Effusions we have gone through effusions. When there is big effusions, it starts to push the things to the other side. When it is collapse, it is pulling everything to its sides, to the pathological sides. And we said small effusions are not detectable because they are going to the posterior side, but you can see it on the lateral here, lateral graph, but on the PA, nothing shows up. So if the amount is getting bigger, it starts to lift the lung upwards. So you start to see it on the PA. It blunts the Costophonic angle. Some mid-sized effusion here. And when there's adhesions, like things are adhering, and it's the pleural, there's some pathology in the pleural space itself, pleural linings, then it can be loculated collections, like this one, for example. And this one, this time the fluid is in the horizontal fissure. So it is between the top lobe and the middle lobe. And you make another radiograph to the patient the next day, and it can disappear completely. Like if this opens and the fluid falls down, then it's going to disappear completely. This is called the reason why these are called phantom tumors, like ghost tumors. So they can be like some large tumor one day, and the next day it can totally disappear. You can detect it with very sharp contours. You detect these lesions. It has a very typical spacing and a typical appearance. So when I see these kind of things, like it's easy for me to detect. When you look at the pleural effusion causes, it can be many things. Heart failure. In case of malignancy, it can, because it's secreting and it's bleeding, its malignant effusions can occur. Infections. In case of pancreatitis, we had a patient like that in ER lecture. Also, rheumatological diseases with this affecting, which is causing inflammation on the pleura, can also happen to secrete those secretions and cause pleural effusions. Also, hypoalbuminemia is characterized with fluid loss into all of the spaces, not only pleura, but also pericardial and peritoneal space. The position of the patient, the rotational angulation, of the patient is very important. When you are making from the right angle, it shows like this. But in a case of this, for example, when you're doing a lordotic scan, then it, because it doesn't have a sharp border now the border is very sharp, but when you're making angulating, it has a very non-distinct appearance. Then it looks like a consolidation. It can really change appearance according to the angulation. All right. So when it comes to pleura, we always remember there can be mass lesions and calcified plaques in patients. Calcified plaques usually happen in patients with asbestosis. And loculated effusions, they do not completely go down. They happen to locate in here and there. This is a patient with probably a malignancy. These are probably some solid lesions, accompanying solid lesions as well. But I can see the costophonic blunting, right? I'm definitely sure there's some effusion here. But here, it's either solid or maybe fluid. We don't know. We can't. Can you see anything abnormal here? The right hemidiaphragm is markedly elevated, right? And it doesn't really look like an effusion, by the way, because the costophonic angle is, we can see the costophonic angle. Listen, this can be pleural effusion too. Some effusions look like this. They lift the lung to some area, but the lung usually, the edge usually sticks to the pleura, and it looks like this. But in case of this appearance, we should always also remember the elevation of the hemidiaphragm below it. Okay, this happens with phrenic nerve paralysis, because the nerve is paralyzed, it just goes up. And also when there's some subdiaphragmatic collection, like some abscess in the liver, for example, it lifts the hemidiaphragm. Usually, by the way, the left down is higher, but not this high. I mean, it's usually like 3 centimeters. Left is higher. The right is higher. Left is lower. It usually has appearance like this. There is some miswriting here. Please beware. The left hemidiaphragm is lower because there is heart. Heart is pushing the diaphragm a little bit lower, so the right side can be less. The right side should be higher. It's just the opposite. We can correct it. All right, but not this much. Okay. Can you see any abnormality here, people? When we are looking at the pleural linings, we should be looking below the pleura as well. There's some free fluid under the diaphragm on the left side. It really doesn't look like some stomach gas. Stomach gas is here. It's usually like widespread, and the contour is the diaphragm, so there's free air under the diaphragm. This is a very important diagnosis. Like, I think most of you people had diagnosed this before I told you. Please do not miss it. Can you see any abnormality here? Also this one. I'm seeing something behind the heart here. There's some area of air which is not supposed to be there, actually. These are cases of hiatal hernias. These are stomach which has gone through the hernia and went up to the thoracic cavity. This is not an abscess. It's very common in a case of like this. You should always think of hiatal hernia first and abscess second. It can be an abscess. You cannot differentiate it, but mostly these are hernias. So this is a case of Punoma Pericardium. Now the pericard is lined by some air. I can see the pericardial lining and the heart separately. So when there is air in the mediastinum, it's Pinot Mediastinum. It's Punoma Pericardium, and it's in pericardium. That's the basic terminology. Does anybody see anything abnormal? I'm seeing something.
Hocam sağ altta serbest hava var sanırım.
Some air under the diaphragm. That's true. But if you look at it a little bit carefully, doctor, thanks for the diagnosis, by the way, it's actually lined by the colonic lining. So this is actually colon, which has gone up the liver, and it is actually not free air, but the loculated air inside the colon. But thanks for the diagnosis. Please do not remember this case. The air can belong to many other things as well. Okay. When we come to, I want to speak about diffuse lung disease a little bit. This is a case of hyperinflation, people. If I count the ribs, it's first, second, 3, 4, 5, 6, 7. I'm counting 7 ribs. On the posterior, one thing is I notice is that the distance between the costas are pretty much higher than normal. It is like the lung is the air inside the lung is increasing. Also, the diaphragms are looking flat instead of their normal round appearance. They are looking much flatter, and the heart it looks like a drop. You know, it dropped down. This case is cases of chronic obstructive disease, lung disease. These are the important findings you should look for. These are usually very thin patients who have some cigarettes who you can see cigarettes on their pockets, usually total smokers. And coming from that, now I think we have finished everything except the lungs, as you have realized. So let me look at that. Yeah. So we have looked through everything in this 160 slides except lung areas. So let's go to lung areas then. Let's go to airspace opacities. Now we are starting the real deal about chest X-rays. So we define opacities and the same thing as densities in chest X-ray, as you know. And when there is less of a density, we call it lucency, right? So lucencies are darker, densities are brighter usually in an image. When you look at the airspace opacities, I will see a very distinct, two distinct appearances, which can be differentiated between one another. One is on the left and the other is right. I'm seeing sometimes some hazy appearance, which doesn't have sharp borders. It's like clouds, right? I cannot see anything sharp. It's very hazy, and its borders are not very distinct. I don't know where it starts. It's hard to say where it starts and where is the end of it. On the other hand, sometimes I see some markings which are very sharply lineated, like lines, for example. These two have different namings, terminology. The one on the left is called alveolar densities. The one on the right is called interstitial densities. And I will describe them in detail. So the airspace opacities are very important, and they can be very good questions in even the theoretical ones, and also in the oral exam in your daily practice as a doctor when you become a doctor. And it will help you a lot in differentiating the disease and naming the diagnosis. So you should be very good with the patterns, educate your eye. So some density in the airspace could be located in the alveoles. When they are located in the alveoles, they basically look like this. They have a hazy appearance, they have an alveolar density, and they are called consolidations. On the other hand, they can be located not inside the alveoles, but in the area which is between the alveoles. So when they located in that area, they are not hazy, but they are like lines. These are called interstitial lines, interstitial markings. And other than that, they can be, of course, nodules and masses, which are completely different family, and they can be related to a collapse of some part of the lung, which will be called atelectasis. Alveolar opacities are called consolidations. Consolidations is an airspace opacification, which is a descriptive term, which refers to filling of the pulmonary tree with material. It will have a hazy appearance, as I have told you, and interstitial linings is usually related to involvement of the supporting tissue of the lung. So it will have a fine, coarse, lining, linear opacities. Nodule and atelectasis are things we can, I think, imagine in our minds. So let me come to this later, all right? Let me describe it a little bit more. The key findings in consolidation in alveolar opacities is that they should be ill-defined. The markings, where it ends, where it starts, it should be hazy. It can cause silhouette signs according to the area which is sitting next to. It will cause air bronchograms. Air bronchograms are because the space inside the alveolar is filled up. Then you will see the bronchus as dark structures within the lung. Usually what we are seeing usually is we see the blood vessels in a lung X-ray, right? Like this. We see the blood vessels, and the bronchus are actually not seen because they are in low density. But in case of consolidation, we will start seeing the bronchus wall as a dark structure instead of a bright blood vessel. So the appearance is changing from bright to dark. I mean, I was on the normal scan, I'm seeing normal blood vessels. In a case of consolidation, I will start to see the air-filled bronchus. Was it a little bit clear? I will come to this. It will extend to the area which it is limited, the fissures, but it will hardly cross it because it is located to the alveoles, and there will be no volume loss. And in a case of this, for example, I'm seeing areas of hazy appearance inside the right lung. The left one is normal, so the borders are not very clear. In this area, I have seen the bronchus here as a dark structure, which is totally not seen here. Can you see it? And this time there is no pleural fissural extension, so these are not present, and silhouette sign is not present, so it's not a must. But the hazy appearance should be like we should educate our eyes. Something we should educate our eyes. Another case of consolidation. This is an alveolar opacity. The borders are not very clear, so this is not a mass lesion, right? Doesn't look like a mass lesion. It is hazy. It's like a cloudy appearance. And I'm not seeing any bronchus wall inside it. So it's not a must, but it's definitely a consolidation. Another case of consolidation with ill-defined borders, and it's got some bronchus wall I can see inside it. And I can see the bronchus wall, which is lining the consolidation also as well. Very, very typical good case. Also, I'm seeing some pleural effusion here as well, right? And the lung is gone upwards. The hemidiaphragm is elevated. This is a typical case of pneumonia, for example. A very big case of pneumonia, a big area which is infected, which caused also effusion because of the inflammation. Okay, so there are a lot of things that can cause these consolidations. When it is loculated, we should always think of pneumonias, for example. And cases like pulmonary hemorrhages, lymphomas, interstitial lung disease, like eosinophilic pneumonias, sarcoidosis, and anything, many diseases can cause consolidation. When it is diffuse, we should always remember heart failure. I will come to this. And when it is multifocal, it is not localated to only some area, but it is here and there. When it is multifocal infiltration, I should always think of, for example, COVID, right? Like this was something done before the COVID times, some table, so it's not present. Tuberculosis, also other pneumonia bacteria can cause this. But normally, bacteria like staph or gram-negative bacteria cause lobar pneumonia. Okay. Another typical example of consolidation. Hazy appearance. It's not nodule, it's not a mass, and it doesn't contain any lines. Very hazy. Okay. The air bronchograms are, I have described you this before. So in a case of consolidation, because the bronchus wall are empty inside, there is air, I will start to see the bronchus wall in a case of consolidation. On CT, it looks like this. So on a chest X-ray, you are actually seeing this appearance. In a very severe case, it looks like this. It doesn't usually normally look like this. But normally on CT, air bronchograms look like this. In chest X-ray, they look also pretty similar. It can be helpful though. In this case, for example, are you seeing anything? It's a very difficult case to actually for the diagnosis. It's because it is behind the heart, people. So I'm seeing the bronchus here very sharply, and I can follow it all the way down. Also, I'm seeing something right behind the border of the heart, some hazy appearance. So there is actually some area of consolidation in this area. This is a left lower lobe pneumonia. As I have told you in the systematic evaluation, there is some lung behind the heart as well. We should be looking at this area, and there is lung behind the diaphragms as well. There can be mass lesions behind the diaphragm, for example, and there can be consolidations behind the heart. You should always be careful about these areas. So these are different cases of, again, consolidations, okay? Let's go over them. The first one is lobar pneumonia. Now the patient has cough and fever, so you should always think of the clinical perspective, look at the laboratory, the symptoms, and the lung X-ray to decide what can be the pathology behind this. Okay. In the case of the second, it's a pulmonary hemorrhage case. So the patient is having big amounts of hemoptysis from the mouth, and it causes some consolidating area in the lung. The third one is organizing pneumonia, which is an interstitial lung disease, which has patchy areas of consolidations. This looks like a mass, but the others are consolidating areas. On the case of fourth case, this is a pulmonary emboli case because the area of this, because the circulation is disrupted here, it caused consolidation. The fifth case is a definite case for heart failure, because I'm seeing consolidations, right? Some hazy appearances, but at the same time, I'm seeing some linear densities as well. We will come to that. This is a typical case of interstitial densities that I have been telling you. It will be our next topic in this lecture. And the sixth one is also sarcoidosis, which caused some hazy appearances of consolidations in the lungs. So, when it comes to diffuse consolidation on both sides, you should always consider heart failure. Why we should always consider heart failure? It's an actually very easy question. The reason is because 50% of us is going to die from heart disease. It is very common. It's very common. This is something you will very commonly see. The things which are typical for heart failure is that I will see a big heart, right? In a case of heart failure. First of all, I'm seeing the enlargement of the heart, and then I'm seeing big consolidating areas which are symmetrical on both sides. It can be a both side pneumonia as well, but well, not very common. And the peripheral sides are usually normal in a case of heart failure. So the heart failure starts from the center as a consolidation, and it will go towards the periphery. Also, because of the pulmonary edema, which is happening at the same time as well, there I will be start to see some linear densities, like line-like densities, close to the peripheral area, like this. Okay. Let us go through other examples that can be helpful for us. This is a case of Legionella Pneumonia, by the way. So I put this in order to show you how similar it can look. So without looking at the clinical perspective, it is very hard to name the diagnosis just looking at the image. So you should always combine these findings all together, people. The patient is intubated. It has consolidations on the left and right side. And there is also some linings, linear linings as well. The reason that we are seeing this can be also because the patient is also having some episode of heart failure at the same time because of the pneumonia. So pneumonia can cause heart failure as well. Also, when you're seeing a case of heart failure, for example, like this, you should always consider maybe the patient had pneumonia in the right upper lobe first, and then the patient get like circulatory insufficiency because of the pneumonia, which happens a lot with old people. So the patient has also go into insufficiency and pulmonary edema. Okay, in this case, we are seeing patchy consolidations, some consolidation here, some consolidation here, something here, and some small area here as well. What would you think of if you see a patient like this today?
COVID patient.
COVID, right? Great, doctor. Thank you. Typical case for COVID. This can happen. Very good one. Thank you. So when we come to interstitial findings, it will originate from involvement of the supporting tissue of the lung, not the alveoles, but this time the supporting tissue. Okay. So a typical interstitial look will look like this. So in the long run, this will go to fibrosis of the lung, but also it can be because of the edema of the lung, which will be caused by heart failure, as I have told you a little while ago. So normally the heart will look like this on a histological on a microscope. In case of edema, the supporting tissue of the lung is going to be increased. So we will start to see lines, interstitial appearance, reticular appearances. Okay. This also happens in cases of heart failure, as I have told. So apart from seeing consolidations, when we are seeing linear densities, we should always consider heart failure as well. Not because it is very typical, but because it is very common. Usually this kind of interstitial appearances happens with people with pulmonary fibrosis, for example, or interstitial lung diseases. But well, how many times are you going to see an interstitial lung disease? And how many times are you going to see heart failure, right? So the etiology of interstitial disease is very, very wide. It can start with pulmonary edema, with heart failure. It can go to viral pneumonia. It can go to interstitial lung diseases like usual interstitial pneumonia and idiopathic pulmonary fibrosis. Sometimes drugs cause pulmonary fibrosis, so they will have this reticular, they will cause this reticular areas, opacities. And in terms of when we are talking about interstitial pattern, we should always keep in mind the interstitial lines which is happening in heart failure. These are called Kerler B lines. They will be perpendicular to the pleural wall, and there are caused by the edema in the lung tissue. So the interstitial linings, the interstitial area is going to be increased because of the edema. When there is no fluid inside the alveoles, but there is fluid inside the interstitial area, it will cause these reticular opacities, which will go all the way to the periphery of the lung and cause this Kerley B lines. It's a typical appearance for interstitial edema in heart failure. On CT scan, it looks like this. On CT scan, you will see the lines which are between the lobules of the lungs. So when you look at the CT scan, you can just a little bit understand it better, in my opinion. And this is a typical case of interstitial edema in a heart failure case. Nevertheless, I'm trying to give you a general idea of the things. So always consider it can be this area, this appearance, sorry, can very well be an interstitial lung disease as well. Okay. This time it's a patient with sarcoidosis. So we are seeing interstitial changes and these lines which are directed in different areas of the lungs. Another patient with interstitial changes on sarcoidosis, and this time I think left lung is more affected. 8 years later, after treatment, these lines have disappeared and some fibrotic lines are left. These are areas of fibrosis. So when we are talking about interstitial patterns, like the diseases of the interstitium, it's usually most of the time reticular. Sometimes nodular appearances can be the profound appearance as well. Sometimes they are both seen together. And when there's too many lines, we are talking about reticular opacities. When there's too many dots, we are talking about nodular densities. When we are seeing both of them together, we will call them reticulonodular densities. These are different from pulmonary nodules because pulmonary nodules are less in number, of course. They are not like hundreds altogether, and they are bigger, much bigger. These nodules are much smaller, as you have seen. So when we come to pneumonia, how can we? What type of appearances are they going to make? If you want to talk about it, they are usually causing consolidations. So in case of lobar pneumonia, the radiographic features are mostly consolidations. But in areas of interstitial pneumonia, for example, there are reticular pattern as well. So viral pneumonias or mycoplasma pneumonias, they sometimes cause this reticular opacities. So when you're seeing a reticular opacity, it can also be caused by pneumonia as well. There is something called round pneumonia, which is basically looks like a spherical opacification, like consolidation area. And when it causes a cavity, well, it is very easy to see actually. So this is a case of lobar pneumonia. It affects the lobe. It doesn't cross the fissure, and it causes some opacification of the lung area. But in some other cases, in viral cases, for example, sometimes it is small dots. So when you see the radiograph, it will appear as small dots and reticular lines altogether. Another case of lower lobe pneumonia, which is coming with just consolidation, and that's all. Nodules and masses are very typical. We know them, all of them. When you're looking at one thing, I would like you to know about nodules is
Hocam,
the
I
threshold.
have a question.
Yes.
For lobar pneumonia,
Yes.
it can be sharply, sharp, or it can be consolidated.
Oh, good question. Good question. I think your question is coming from this one, right? This one on the left. Yeah. Look, on the lower part, there is no distinct border, right? So, like when you don't think of this area, but look only here, it looks like consolidation, right?
Yeah.
Yeah. But here it doesn't look like consolidation. It has a very sharp border. Why is this? Because the consolidation is reaching the upper border of the middle lobe, and the consolidation cannot pass through the fissures of the lungs because it's it's obstructed. So consolidations cannot cross the fissures. It's the reason why it's having a sharp border actually. Not clear? Yeah, look at this one.
Thanks.
Look at this one. It's much clearer like this. It cannot go to the lower lobe because it's a middle lobe pneumonia, right? The middle lobe pneumonia is here. Inside the pneumonia, it's having some hazy appearances, but because it cannot cross the border, it will have sharp linings on between the lobes. That's the reason why. Okay. So we have come to nodules. I want you to remember that we are following up these nodules because they can turn into cancer. We are following up these nodules. Our limit is 4 millimeters. Okay. In high risk patients, anything bigger or either 4 millimeters and bigger should be investigated. You should remember this one. We have around 30 slides to go, and I need to make it somewhere at 4 o'clock. I think I won't be making up any lecture today, so we have the tomorrow left. Let's schedule something for tomorrow. I want to finish this lecture in English. Hello everyone. So we are left in the nodules. We are speaking about. We are closing to the end, getting closer to the end of the lecture, and now we're in the most important one. We are going for airspace opacities. Okay. So starting after the break, what was airspace opacities? They were either consolidations, they were either interstitial opacities, they were either nodules or masses, or they were atelectasis. There are 4 of them. So consolidation is actually alveolar opacity, and it has only one terminology. Consolidation is alveolar opacity is consolidation. When it comes to interstitial opacities, we were talking about 2 different types: reticular or nodular types, or reticular nodular types, like both of them together. These are all interstitial types of interstitial opacities. Then we will come to nodules, masses like mass lesions, and then the atelectasis, and it will be covering up all of airspace opacities. Okay. For nodules, as I was telling you, people, we are following them up according to guidelines. The guidelines can change. It's the same thing with head traumas and everything. But just remember there is some guideline for nodules, and you have to look at that to give recommendations to the patient. And the limit is 4 millimeters. Okay. For a 4 millimeter nodule in a non-smoking patient, for example, I'm looking at the guideline now, no further investigation is needed. But for patients with risk, smoking, family history, this and that, or asbestosis, SCT is recommended. So these are detailed guidelines. Don't just remember the name. Just remember that there is a guideline and that's all. Okay, you can always Google. So we are seeing examples of nodules now. I'm recording, okay. Okay, so when it comes to airspace, I was mentioning about the airways, if you remember, about bronchitis. So you should always also remember peribronchial coughing or peribronchial thickening, because why? Because the symptoms can be very similar. Okay, in a child with cough and fever, sometimes you see no infiltration, but it is usually viral bronchitis, for example. So peribronchial coughing, when you see the bronchus with a thick wall, you should always look for this pathology. Okay. So we have completed airspace opacities. Now we are coming to the lucencies, the dark areas. When it comes to lucencies, there are 3 types of lucencies that we should know. One is cavity, which means a lucency with a thick wall, and cyst, lucency with a thin wall, and then some lucency without a wall. I mean absence of lung tissue, which is emphysema. So cavities, cyst, and emphysema are 3 types of airspace lucencies. Okay. There are multiple etiologies that we can think of. Sometimes, usually cavities are formed by infections, right? Sometimes when there's a big mass lesion like a cancer and it has necrosis inside, it forms a cavity after necrosis, especially with squamous cell. I will not ask this, don't worry, but always remember that for cavities you should think of pneumonia and sometimes mass. Okay. When you see, please listen, when you see a lucency with a wall in chest X-ray, it is almost always cavity, because cysts have very thin walls, like either smaller than 3 millimeters. It is very hard to see them on chest X-ray. So when you see something, please, with a thin wall, please do not think of it as a cyst, but more of a cavity first. Okay, it's usually because when you see the wall, it's usually cavity. Bronchogenic cysts, which are congenital cysts, and congenital cystic adenoid malformations are cystic lesions of the lung. Also, after trauma, sometimes bules and pneumata cells can happen. When we are seeing multiple cysts or multiple cavities, we can think of many things. Multiple cavities, usually we should think of something like tuberculosis, for example. Also, some neoplasms with metastasis, and some cystic lung diseases can do that. Okay. Let's look at this case. We are seeing a lot of cavities with a thick wall, right? I can see the wall. I can see some fluid leveling even in this one. It looks like an abscess. So this is an HIV pneumonia. Nowadays, we are rarely seeing that because antiviral therapy for HIV is getting much better. We are almost never after this time in the recent years, we are not losing any patient from HIV, which is a very, very, very big advancement of the science. When you are seeing a big cavity lesion with a density inside, these are mostly fungus balls. This can happen with a lot of people, even with people who are not immune deficient, because a cavity is actually empty inside. So the immune system cannot reach inside. When the patient has a cavity out of some reason, like trauma, this congenital, this type of fungus pneumonia can occur very very commonly. It's something we see very commonly. Please remember that one. Also, when you're seeing something like this with a fluid level, what should be thinking about? We should be thinking about abscess. Okay, this looks like an abscess. It's a very big source of infection. Probably something congenital. It's a child which is infected. So, but when it comes to lucency with all the visible wall, we should be thinking about emphysema. Thus, this should direct us to chronic obstructive lung disease. Okay. Emphysema looks like this, people. It's basically absence of functional lung tissue. It has no wall whatsoever. In these cases, it's usually it's not usually very loculated, but mostly in especially older generation people, it's pretty much diffuse, mostly on the top sides, but on the bottom sides as well. So chronic obstructive lung disease should be also always on mind. It's a very common disease, as you know. This is another source of, yes, please.
For X-ray, the previous one.
Yep.
Can you define the lesions here in the chest X-ray?
Very good questions. Can you, doctor, please define the lesions?
I think there is a bit.
You can't.
No.
Can you?
Okay.
You can't because there is no lesion. It is absence of the density. So there is no density here. There is increased lucency generally. What I can do is that I can count the ribs, right? 1, 2, 3, 4, 5, 6, 7. Okay. So there is increased lucency here. The heart is like a drop shaped. You know, I'm not seeing a regular heart. The diaphragm is pretty much flat. And the lung markings, like I see lung markings in the center, and they usually reach to the periphery. But areas like this, for example, and like this, they have very little bronchovascular appearance at all. So it is basically absence of lung tissue. You can think of it like that. All right. So you cannot see this. You cannot define the demarcated lesion here. There is no demarcated lesion. This is chronic obstructive lung disease, basically. On chest X-ray, it looks like on chest CT, it looks like this. So it's basically lowered density all over the lung, especially on the top parts. By the way, was it clear? I guess so. Okay. Also, so lucent lesion in the airspace can be a very good question. Please remember. So let's look at this image. We are seeing two patients who admit to the emergency department with shortness of breath. Okay, they are having trouble breathing simply. These are two different patients with the same symptom, but with totally different appearance, right? Should I go over with these patients? Let me do it by myself this time. For the patient on the left, I'm seeing a enlarged heart, right? The heart is pretty much enlarged. I can that comes to my I realize it right away. Also, I'm seeing pacemaker. So the patient is probably having some heart problems, some arrhythmias. And on the central part of the lung, I'm seeing big areas of consolidation, some big clouds, which is increasing the density. Also, coming closer to the peripheral areas, I'm seeing that there are increased markings on linear structures, right? Which are coming to the border of the lung. They are perpendicular to the pleural border. So these things are not consolidations, but interstitial opacities. in interstitial opacities, there are not nodular, so there are reticular. So reticular densities which are perpendicular to pleura, I'm seeing. And they are very prominent on the lower parts of the lungs, and in both lungs. So I'm seeing my findings are on both sides. So I'm seeing something symmetrical. It's more likely to be systematic. And coming up these findings, like gathering up these findings, putting them next to each other all together, this patient is a definite, almost definite, most typical case of heart failure. Heart failure, right? So this is a basic heart failure looks like. So let's make a brainstorm a little bit. This patient is sitting at home. So there's a reason why it was sitting at home previous week. It's a reason why it is sitting here in front of you. So we are seeing some typical case of heart failure through that. But I'm just brainstorming. I don't know the definite cause of this patient. For example, there is area increased density, some sort of a consolidation on this area as well. So this patient might probably have some accompanying other disease as well. So there can be some areas of pneumonia here, and because there are increased area of there are consolidations all around, we cannot define them probably. So we should always also consider things which are which can be accompanying, like which can be happening at the same time with all of the patients. Okay. Coming to the one on the right, it is the patient that we have seen in the previous slide, right? The air densities, the inspiration is increased, diaphragms are flat, the heart is dropped down, the area of the markings between the areas between the costas are much more increased. So there is increased aeration of the increased airspace in both lungs. So one is heart failure, the other is a chronic obstructive lung disease patient. We can easily differentiate it with a lung X-ray. Moving up further, I can have volunteers. What is the possible diagnosis in this patient, people?
Is it, I think maybe it's a, no.
Heart failure, I think. Heart failure.
Heart failure, you think. But why?
Looks like increased interstitial edema around the heart.
Interstitial edema, right? We are seeing Kerley B lines. Great, Kerley B lines. I didn't teach you Kerley A or Kerley C or Kerley D. Just know the Kerley B lines, okay? These are Kerley B lines, perpendicular to the pleura. Good. So it's a very good sign. It's in both lungs. Also, the heart is on the limit, right? Pretty much on the limit, almost enlarged. Arcus aorta is prominent, not aneurysmatic, but a little bit prominent. So I'm seeing very fine or coarse, something between fine and coarse, interstitial linings, which are reaching to the pleural space, pleural lining. And these Kerley lines are helping me a lot. It's a typical case of heart failure. Thank you, doctor. Okay, let's come to this one. Does anybody want to have a word?
In the previous slide, there was no consolidation. In the previous slide, there is no.
Yeah, let's look. Here maybe, right? Here
but
maybe.
I mean,
here maybe.
Because the system.
Here maybe, but most prominently interstitial, yes. Not very prominent consolidation. Were you asking something else?
So the key feature for heart failure is the Kerley B line?
No. There's no distinction. Like, you look at this patient and it is a completely different picture, right? It's mostly butterfly edema in this patient. Edema on the central places, right? On the central space. with this case discussions, there are very good cases of heart failure. Please look at them. These links that I've sent you, YouTube links. So, doctors, for this whole lecture, it is actually what I'm trying to say. These are findings. There are key, certain findings you find on a chest X-ray, and there are diseases. So you have to fill in the between. And interstitial linings, as I have told you, the interstitial appearances, reticular appearances, has a very, very long list of differential diagnoses. So can this be a viral pneumonia? Why not? Why not? Can this be usual interstitial pneumonia? Yeah, why not? Who knows? Maybe this patient is in a sarcoidosis attack. We wouldn't know. But statistically speaking, it should be heart failure because it's more common, and basically because it's more common and there is no other symptoms. Also, the heart is enlarged as well. So without looking at the clinical picture of the patient, there is then a chest X-ray doesn't it doesn't. Sometimes, for example, for the case of pneumothorax, yeah, you see the pneumothorax right away, right? Pneumothorax is there and it's pneumothorax. But for airspace opacities, a lot of diseases intersect with each other. I hope it was it answers the question.
Yeah.
All right.
Thanks.
So look at this one, Al Zehra. What do you see?
Yeah, I see the bronchovascular is more dense. Maybe it's pulmonary. No,
Yeah, true that. Good observation. Yeah, bronchovascular markings are pretty prominent on this patient. True that. Okay. What else?
I kind of bronchus, the bronchiole here, on the left.
On the right lung, you mean, right?
Yeah, on the right lung.
On the right lung. You mean like air bronchograms? That's what you want to say?
Yeah, and on the left also, it's so apparent, I feel.
But these are vascular structures, right? These are blood vessels. So yeah, these are not bronchs because they are not empty inside. This is soft tissue density. Okay. So
and also there is addition on the right lung.
There is,
I feel,
some consolidation area on the right lung, right? This is a very prominent finding. Good. What else?
Is consolidation.
It's consolidation. It is hazy, right? It doesn't. You cannot know the borders. Also, it gives a distinct borders on the horizontal fissure. So, to which lobe does this belong to? Can you make an assumption?
To the middle lobe.
Right middle lobe. Great. Yeah. Thank you. So I'm seeing some consolidation on the right middle lobe, and no consolidation in other parts of the lungs. So what could be your primary diagnosis for this type of a patient?
Is it pneumonia?
Pneumonia, right? Pneumonia. Typically, we should consider pneumonia. Can this be pulmonary embolism on the right middle main artery, which is blocking the view, so causing pulmonary infarct? Very well, yes. Very well, yes. Because it can come with consolidation as well. So you have to look at the clinical picture, but this is also we are seeing the oblique fissure on the lateral graph and the horizontal fissure on the top. So this is some right middle lobe, consolidation on right middle lobe, mostly consistent with pneumonia. Thank you.
Thanks, Okan.
I did see also air bronchogram. I see consolidation. The costophonic sinuses are open. There is no pneumothorax. We should always look for every pathology in every patient. Please remember. All right. Let's go to this one. So when I start a patient, this is what there will be no other case discussion. Unfortunately, these are the cases we're going to discuss. It's all mixed together now. So when you're entering an exam, please start with a very quick technical evaluation. I'm looking at the clavicles. They are a little bit rotated on the left, to the left. And I can see the vertebral bodies. The inspiration, I'm counting ribs, 1, 2, 3, 4, 5, 6. It is enough. And the rotation is, I can see the apex of the lungs. In 10-15 seconds, I finished the technical evaluation, right? So I will go to the systematical approach now. Let me see, let's say I'm the student. I started going from outwards to inside. I started from the most lateral pieces. Humeral heads are cool. Clavicles are good. I'm looking at the soft tissues. I cannot see the neck. The axillas are good, by the way. I started finding some pathology, free air on soft tissues of the right lung, left lung, I'm sorry. Okay, this is a good start. And then I started looking at the Costophonic angles, which is open here, which is blunt here, right? So I'm seeing a fluid leveling. There's fluid leveling, so there's definitely effusion here on the left side. I don't stop, I continue. All right, I started looking for the costa. The costas are going well here. And somebody's microphone is open. Yunus Emre. Okay. I'm looking at the other costa because I see air in the soft tissues. I'm looking for costa fractures, and I couldn't find any. I couldn't find costa fractures, so I started looking at the lung areas. I'm seeing a lot of nodular densities, diffusely distributed on the right lung, right? So there are a lot of nodular densities which belong to interstitial density family. And on the other side, I'm not seeing any lung at all, right? I'm seeing a complete empty airspace. So what is the pathology in this patient? What is the Mayer pathology?
Collapsed lung.
Collapsed lung, right? This is big area of pneumothorax here, which is the main problem. It doesn't.
Pneumothorax, I think.
Not okay. Not very, right? A little bit, maybe a little bit. So because the aeration of the right lung is pretty much okay, but there is some. It is here. It is starting to push the heart to the other side. So the lung has probably collapsed. This is the collapsed lung here, and this is the free fluid leveling. So we are seeing pleural effusion, subcutaneous emphysema on the left side, big area of pneumothorax, and also interstitial nodular densities on the right lung. The heart is good size. The airspace is open. There is an area of Punoma Mediastinum here as well, in my opinion, which is very subtle. Like, I'm not sure of this finding. So if I don't approach to this systematically, I could easily get lost. So that's going to be our dictionary. We should always start with any kind of systematic approach: inside out, outside in, A, B, C, D, whatever. This was a difficult case.
So it's a mixed case. What's the main problem here? Like,
what's the main problem?
The other?
Well, I think the main problem is the pneumothorax on the left side, first of all. Right, doctor? Pneumothorax can be life-threatening. Reticular nodular densities on the right side are probably there for years. Or maybe the patient has miliary tuberculosis, let's say. Or maybe interstitial lung disease, which is causing this. Also, the interstitial lung disease may have caused pneumothorax. So, yeah, you look at the clinical condition of the patient and decide what to do next. In this case, it's obviously pneumothorax, of course.
So, Hisham, what are you expecting from us in the oral exam to discuss the technical evaluation and the systematic evaluation? But because I feel it's so hard to say what's the diagnosis. We can tell the what are the pathologies, but not the diagnosis.
Let's put it like this. I will be expecting every word I have been telling for the last 5 minutes, Zehra. I don't know what else to say. Like, I don't want you to treat the patient, right? You are in a radiology course, so you have to explain the radiological findings, okay? So I'm not going. You asked the same question 2 lectures ago as well. Anyway.
Not me.
So you see the pneumothorax, right? So you have to name the pneumothorax. We have seeing fluid leveling, which is pleural effusion. We have to name this. We are seeing interstitial nodular findings. We have to name this. So when it comes to interstitial nodular densities, the interstitial nodular densities have a very wide range of differential diagnosis. So in a very typical case, maybe you can come up to some pre-diagnoses, but other than that, you cannot look at the image and say what the disease have, what the patient is suffering from, right? You can say that there is pneumothorax here, and you can see that there is pneumothorax. Okay. So when it comes to the exam, it will be pretty much what I have been describing for in case of this lung X-ray, for example. It will be consisting of you making a technical evaluation, you making a systematical evaluation, and trying to come up with a differential diagnosis. Neither your exam nor your lectures were some memorizing lines and trying to find them in a multiple choice setup. It's not like that. It's so I cannot truly say if you should find this disease or that disease, but on the way I have been telling you about a lot differential diagnosis and some major diseases that you really shouldn't miss at all, and there are some other diseases that you should always keep in mind, in the back of your mind, since they are very important for you. So I cannot guarantee you that I will not ask you any disease. I can come up sometimes in the oral exam. I ask some diseases, and when they're not answered, it really it has a very negative effect on the marks. Sometimes I ask very fundamental radiological signs, like this left pneumothorax in this patient, for example. So it will be a mix of everything, and it will be a mix of everything I have told, and everything which you can find in the YouTube channel. Let's go to the next patient. This is the diagnosis is pretty obvious. I didn't show you any case of this, so it will be a mixed pathologies altogether. We are seeing subcutaneous air in this patient. Also, the air can move freely within the soft tissues, so I'm seeing free air around the trachea, which is called Punoma Mediastinum. Diagnosis of this is very difficult, so it won't be. There's no case of Punoma Mediastinum in your oral exam, for example. So this Punoma Mediastinum has actually reached to pericardium as well. This is probably Punoma Mediastinum going behind the pericardium. This is not Punoma Pericardium probably, but also in this patient we are seeing free air under the diaphragm as well, right? We are seeing free air under the diaphragm too. Okay, let's move on to the next one. That's another case with a CT scan in hand as well. Some Punoma Mediastinum which is encircling the heart and also going up around the neck as well. This is no Punoma Pericardium, but you can, if you call this Punoma Pericardium, I would understand. Like, I will not ask about the differential diagnosis of this. It will be just too much for you. Please stick to the basics and know the basics and don't make any mistake. That's all. Can anybody make an evaluation about the lung areas in this patient on the left in the chest X-ray? I'm seeing a lot of interstitial reticular opacities, right? Like all around, here, here, here, here, here, and here in these areas as well. So can this be pulmonary edema? This can be very well a heart failure, right? It looks like heart failure. But if you look at, because these are the same patient, if you look at the same patient CT scan, these are actually not pulmonary edema, not like edema structures, but mostly fibrotic changes. Mostly, I'm sorry. Mostly fibrotic reticular lines. Let's say it like that. These are cases of emphysema with thick walls, for example. But defining the interstitial opacities and maybe some areas of consolidation on the left side is enough for us in the radiological perspective. Then when it comes to making the differential diagnosis, it can be sometimes hard in patients, even for radiologists like us. Let's come up with this one. This patient is coming with his history. So in oral exam, it is usually like this. A 50-year-old smoker, man, I guess, no breast, no history, no significant history in his medical history. He's suffering 2 months of progressive dyspnea in this patient. Does anybody want to evaluate? Berk, for example. Are you ready, Berk? Can you take the mic? Or Zehra? Or Abdulmelik?
I can see opacities on the right line at the borders.
Yes.
At the left side of the heart, there's a consolidation. I don't know if it's infection or
You mean
maybe,
this area? You mean this area?
Yeah.
Okay.
But yeah, everything is normal. I mean, in a systemic way, you can count ribs. The clavicles are okay. There's no rotation. I can see the trachea and the bronchus, 2 bronchus.
There is actually rotation, right? A little bit of rotation. The patient is rotated a little bit on the left.
Okay.
I should also count with counting the ribs. 1, 2, 3, 4, 5, 6. So it's enough. All right. The dosing is good. I can see the vertebral bodies even up to here, and the lungs are going okay. The dosage is fine. And the rotation, I can see the apex of the lungs. Okay, 15 seconds, you make the technical evaluation in every patient in an oral exam, up to make, okay? You have to make the technical evaluation and see what are the shortcomings and which are good and which are not. So when you're looking at the systematic level, what do you see in this lung X-ray? Where do you want to start? Let's put it like that.
If you want to start from the lateral side, like what I said, you can see more dense areas than the medial side.
Yeah.
And we can see at the hilar region, there's opacities too.
Yes.
Maybe good. And on the left side as well. So I think it's a systemic, not an infection.
Good.
Something.
Yes.
What is like to have a COPT actually?
For COPT, chronic obstructive pulmonary disorder, I have to see the inspiration is getting higher, the air trapping inside the lung, right? But when I count the ribs, it ended in the 6th one, and the diaphragms are looking quite curvy, so they are not very flat. The heart is not like a drop sign, right? There is cardiomegaly actually. You didn't mention that one, for example. So
is there any reticular opacities?
There are a lot of reticular opacities, plus nodular opacities as well. So, Abdulmelik, I want you guys to be starting systematically and saying, for example, I'm seeing the scapula and it is fine. I look at the clavicles, I look at the other femoral head, I saw the borders of the scapula on both sides, and they are fine. So I want to go inside. I look at the Costophonic angles. The angles are open on the right. It's pretty much open on the left. Maybe there can be very, very small effusion, but I think it is mostly due to the nodular densities on the lungs. And there is no costal fractures. When I look at the lungs, I'm seeing that the lung area is very coarse. There are a lot of things, a lot of opacities in the lungs. Most of them are reticular opacities. Some of them are nodular opacities, right? I'm seeing a lot of nodular opacities on both lungs as well. So I'm seeing reticular nodular opacities and some peribronchial coughing here, for example, as well. And this is the hard border. So this is not a consolidation area. Also, the aortic arc is prominent. We have to say this. We have to measure this. If it is bigger than 4 centimeters, we should send to cardiology department, for example. This is the border of the descending aorta. It is going down. This is the aorta. So moving on, I have seen the aorta prominent, and I have seen the heart is, I think it is enlarged, right? It is more than 50% of the thorax. So I have to say it is either on the limit or it is close to being enlarged. And also we have defined some findings in the lungs, right? What we have defined, we said there are reticular and nodular densities in both lungs and both on the peripheries as well. And on the central part, but more on the peripheries. So what can be this patient, for example? You questioned something systematic, which was good. Thank you for that.
Could it be COVID-19?
In COVID, it should be more like consolidations, right? It is patchy consolidations. COVID is like consolidations. It should be more hazy. Can it be
Can
COVID?
we say it's
can be
miliary
COVID.
tuberculosis?
In miliary tuberculosis, yeah, very well, yes, but it should be more nodulars, and there are a lot of reticular densities, which is very uncommon in primary tuberculosis.
So it's something with the heart, I think, because
it can be heart failure, right? It can very well be heart failure through that. But this patient is a smoker, and he's describing progressive dyspnea over time recently. And we are seeing a lot of interstitial changes on the lungs, on both lungs, no consolidation, and more interstitial changes on the lateral sides, like the thing is going on more on pleural sides. So I would be thinking this patient have more likely to have an interstitial lung disease, some interstitial lung disease related to smoking. Actually, I know the diagnosis of this case, so it is actually interstitial lung disease. But it can very well be atypical pneumonia as well. Maybe some here, some atypical viral pneumonia. Thanks for the diagnosis. These are all true, but for a case of atypical pneumonia, for example, it shouldn't be progressive dyspnea over 2 months period, doctor, right? So it should be something like 5 days old problem. 5 days old problem with fever, for example. So you should think of the clinical picture when you are looking at radiological image. That's the reason why we are always asking about the clinical when you are making an order in the ER department. You should include the history of the patient and the clinical condition of the patient when you're ordering a radiological exam. That's the reason why. Okay. So interstitial opacities, predominantly reticular. When they are predominantly reticular, it is mostly interstitial lung disease, atypical pneumonia. Doctor, that was a very good diagnosis. Thank you. Who's that? Farah Süleyman. Asbestosis, chronic aspiration, sarcoidosis, and the list goes on. The list goes on. Okay. We are not seeing any alveolar opacities, and we are reticular nodular interstitial changes on both lungs in this patient. Thank you, Abdel Malik. So this is the type of explanation and evaluation we request on oral exam people. Please remember silhouette sign. Silhouette sign sometimes is very helpful. When there is right lower side pneumonia, it is the lines are obscured, the heart borders are obscured. When there is on the left side, the left borders is obscured. Let's look at this patient. Systematically, no rotation, good dosing. Dosing is good. No angulation. 1, 2, 3, 4, 5, 6. I counted the front ribs. In 10 seconds, I completed the technical evaluation. I look at the systematical review. The bones, I started from outside, that's my way. The bones are okay. The costophonic blunting is not present. The costophonic sinuses are open. Diaphragms are open. Pleural linings are all cool. Heart is not enlarged. Arcus aorta is normal sized. I started going in and looking at the lungs. The lung areas are okay. I'm not seeing any pneumothorax. I look at the lungs. They are pretty cool. I don't see any consolidation nor interstitial changes. These are small blood vessels. I'm seeing some, the hilum of the lungs are prominent, and some some peribronchial coughing. The bronchus are much more visible than normal. So this patient might have, the patient is having prominent pulmonary vessels plus some bronchitis probably. And the heart is okay, as I said. The vertebrae are okay. Behind the heart and behind the diaphragm, there is no additional infiltration. So, so that's another example. Okay. Let's look at this one, please. I would like to have somebody. Abdullah El Arfash. Hey, Abdullah.
Yeah. I'll start by counting the ribs. You can see 1, 2, 3, 4, 5, 6.
1, 2, 3, 4, 5, 6 in the middle.
Yeah. And I can see the APCs.
Which is good inspiration, right?
Yeah.
Okay. Please remember to say that. Okay. Please remember that it is enough. Okay.
The vertebrae are also prominent, so that's good dosing.
Good.
And also the lungs, I can see the airflow. Now I'll start from the outside.
The rotation is good, right? The rotation is good.
Yeah, sorry, the rotation is also good.
The other apexes are visible. Okay. Now technical part is over. It is that easy. 10 seconds. Now move on.
Now I'll look at the pleural lining. And
you check the bones. All right. The pleural lining. You check the pleural lining.
I think it's normal too.
Me too.
And the costophonic angle, they're both sharp.
Good.
Now the heart is, I think it's enlarged.
I agree.
I'm not sure if this is.
It is enlarged, right? It is enlarged. All right.
The aorta is kind of enlarged.
Yeah, aorta is enlarged, right? Aorta is enlarged through that.
Now I'll go to the lungs, and I see this on the right middle lobe. I think there's.
Yeah. Good guess. Good guess. I agree. Good guess. Probably. Okay. What is this? How do you define this radiologically, Abdullah?
I think because it's lobar pneumonia because of the classification.
Yes. But this is an airspace opacity, right? In terms of airspace opacity, this is an alveolar opacity, right? So it is, what do we call this?
Consolidation.
Consolidation, right? Consolidation. Great. Okay. So it doesn't have sharp borders. It is resting on the pleural line. So this can be lobar pneumonia. I agree with you. When you look
because
at
of the enlarged heart. Maybe it's heart failure too.
That's mistake, because heart failure is a systematic disease, so all of the lung is supposed to be affected, right? If it is heart disease, then why is the
It
left
should be
lung
diffuse, you mean?
completely normal? Yeah,
I
the left
understand.
lung is completely normal. If you call this a heart disease, it's minus in the oral exam. It should be more systematically, and the consolidations are supposed to be on the middle, right? It was different. It was not like this. This is more like a triangle, which is resting over there.
Like I said, the lower one. So
Yeah.
it's pneumonia
So
or something like
this
that.
is probably pneumonia. Can this be a case of, for example, pulmonary infarct due to pulmonary emboli, some big pulmonary emboli? Yeah, very well, yes.
Yeah, maybe because it's
We don't have the
yeah.
clinical, man. I don't have the clinical information. Like, what is the CPR of the patient, CRP of the patient? If the C-reactive protein is high, if the patient has fever, if the patient is coughing, if the patient has increased white blood count, then yeah, it's a pneumonia. If the patient has none of this and has this appearance, then, well, maybe it's a mass. Like, who knows, right? This is just an X-ray. All right, thank you, doctor. Good one. I'm looking at this one. It's another case of consolidation. This time on the right, on the left side, on the upper part. This can be this is on the upper zone, so this can be lower lobe or upper lobe. I cannot differentiate because they intersect on one another in chest X-ray. And another patient this time. Can anybody wants to have a word? Let's skip the technical part for this one. And it's on the lung, right? Let's go. I will try to describe the thing I'm seeing on the lung. How do you describe the findings on the lung here? Can anybody have a word?
Hocam isterseniz söyleyebilirim ben.
Buyurun.
Hocam yani tamam şeyi geçtik. Bu
Geçelim
çekim
onu. Akciğer,
şeyini. Şimdi
evet.
solda
Sol.
Bu sol akciğerde bayağı
Güzel.
bir
Evet.
böyle sanki pamuk atılmış gibi gözüküyor.
Süper.
Sanki orada böyle konsolidasyonlar bayağı fazla. Ama belki
Konsolidasyonlar.
atipik pnömoni olabilir. Belki.
Süper. İşte bu kadar
Hani,
ya. Bu kadar. Aynen. Pamuk atılmış dediniz.
Hocam bir de
It is
evet ona benziyor.
It is patchy. Suda said it is patchy.
Aynen.
It's on the left.
Evet hocam ya bunların.
All right. It's consolidation, she said. It's patches, she said. So it's probably atypical pneumonia, she said. And I said, yes, thank you. This case was an aspiration pneumonia, this case. So aspiration pneumonias are actually atypical pneumonias, mostly, because they are anaerobes and they have patchy appearances. The heart is fine. The aorta is a little bit prominent, but it is not aneurysmatic. It is not dilated. That's pretty much it. Thank you, doctor. Yeah, let's look at this one. Lina Bukhemis.
Can you hear me, Huda?
Hello, doctor.
Yes, can you hear me?
Mm-hmm.
Okay, should I do the technical or just start it?
Yeah, just skip to the systematic approach.
Okay, for the systematic approach, I'll be starting from outside. The humerus is not showing, but the clavicles are good. The scapula is good. The ribs, I'm not seeing any fractures.
Mm-hmm.
Okay, for the costophonic, I think it's free. It's good.
Mm-hmm.
Okay, for the trachea, it's showing. There's nothing obstructing it. The heart, I think it's a bit enlarged.
It's big, right? Yes,
Okay.
It's big.
It's cardiomegaly.
Mm-hmm. Yeah.
Okay, for the lungs, it's like increased opacity all over.
All over, good. Mm-hmm.
Yeah.
How do you define the opacities? 4 opacities.
I'm searching for the curly D lines. I think I'm saying that
I'm sorry.
I didn't hear what you said.
I asked about how do you define the opacities? There are 4 different opacities. Airspace opacities.
Yeah,
so these are more like lines, right? More like lines.
Like lines.
Yeah, not like clouds. So
trabecular.
yeah,
Searching for the nodular. I think there's nodular also.
No, it's mostly reticular, I think, mostly reticular. So we are seeing reticulars more also coming through the pleura as well, but also all over. The heart is enlarged, so this can be.
Thinking about the heart failure.
Yeah, this can very well be a heart failure, but also maybe some very old lung which has fibrotic changes, because I'm seeing a little bit pleural thickenings in this patient as well, here and there. Yeah, these are some. Yeah, the lung is old in this patient. It's very coarse, so it can be an interstitial lung disease as well. I'm leaning towards interstitial lung disease in this patient because it's very coarse. This is probably fibrotic changes, but heart failure is very well in our differential diagnosis. It should be always in our differential diagnosis in this patient. Thank you, doctor. That's all. That's pretty much it. Yeah, this is interstitial lung disease. All right. Usual interstitial pneumonia this patient is. This is a trauma patient. What's the diagnosis of this patient? Can anybody, did anybody see something?
It's an AP position, and he has something around his neck.
Yeah, it's AP and something around his neck. Because the patient is supine, it's laying on. It's the trauma patient. They did this when the patient is lying down. Like they put the cassette on the back and make this radiograph.
The right hemidiaphragm is a bit elevated.
Sorry, excuse me.
The right hemidiaphragm.
Yeah, but right one is usually higher, right? Yeah, good catch.
There is clavicle fracture on the right.
There should be clavicle fracture. You mean this one, right? It's not depleted, so probably it's. I think it can be because of the angle, but yeah, maybe here. Maybe. The lungs are okay, right? Lungs are okay. I'm not seeing anything. The heart is, yeah, a little bit big. Look at the humerus head here. Like this is the humeral head, right? And look at the humeral head here. Where is it? It is dislocated. There is humeral dislocation in this patient. It was a very difficult case. I put it for an example. So, so people, as we have been discussing these cases one after another, our salvation is only systemic approach. You find something, I recommend you to do it from outside in. That's my way. And always look for every pathology, because you're going to be working in very difficult conditions under stress. And like if you have a checklist in your mind, it will save you from a lot of mistakes. That's all lecture. Thank you for your attendance, people.